Just such a bizarre, but it is very captivating. It does make you wonder, like, okay, how do we intervene in a way that isn't glorifying the victims or the perpetrators? Yeah.
Right. I mean, yeah, I think that's the hardest part because you're right. It is. It's bizarre. For people who haven't been through it or haven't seen it, it doesn't make sense. And I think that reflects it to the person themselves. It doesn't really make sense. But, you don't see documentaries about a broken leg, but you see documentaries about Munchausen syndrome because it's so unusual and it's not intuitive and it's hard to understand. And it's fantastical in a way. So, yeah, these are the hard cases that we have to deal with and we have to talk about.
Welcome to the Good.Enough.Shrink podcast. We are your hosts. I am Jenna Chang, a child, adolescent, and adult psychiatrist practicing here in Los Angeles, California.
And I'm Dr. Patrick Kelly. I am also a child, adolescent, and adult psychiatrist practicing in the Los Angeles area.
We are on a mission to demystify child psychiatry and have conversations surrounding difficult topics on youth and adult mental health, but not without a little play along the way.
So today we're talking about a topic that fires people up a lot. It involves the legal system, the hospital system as a whole. I think it's just a very systemic issue. It helps me to think of it that way so that I can evoke empathy. But it is the topic of Munchausen syndrome and Munchausen syndrome by proxy. I think people know the name Munchausen, but in the DSM, it's called factitious disorder imposed on self and factitious disorder imposed on others.
This is a condition in which someone fabricates a physical or psychological symptom, and it is a deceptive behavior. And the important criterion here again is that the deceptive behavior is evident even in the absence of obvious external rewards, like
avoiding legal action, financial gain, improving generally physical well-being. And lastly, it's not better explained by other disorders like delusional disorder or psychotic disorder.
Yeah, and I think it's a widely mentioned phenomenon, but also I think a pretty poorly understood phenomenon, even amongst professionals, even amongst people who see it regularly and who treat it.
Yeah. So we'd like to start off with a little history, set ourselves up for the context of this.
It's so funny. I have to admit, This is my favorite part, going through sort of how did these things come to be in the first place. So, I hope the listeners agree with that, but I sometimes get down a little bit of a rabbit hole in this. So we'll try to get to what it actually is in treatment, not just sort of where it came from.
Yeah. I think the very first thing that shocked me about this history is that the first introduction of Munchausen syndrome was in 1951.
Mm-hmm.
It's not very long ago.
No. Yeah. Very recent to be talking about this. And of course, it existed before then. It's like, the Oedipal complex existed way before Oedipus, but that's when it was coined. But yeah, that's super recent.
Yeah. And so it was introduced by a British physician, Richard Asher, in 1951, in his original paper, which described patients who'd presented with dramatic, recurrent, intentionally fabricated medical histories, which often led to unnecessary procedures and investigations. And he called this a common syndrome, which a lot of doctors have seen, but little has been talked about and written about.
Yeah, so he described the three, what he thought of as the most common, so the abdominal type, patients seeking multiple surgeries for different perceived abdominal pains, abdominal problems. In the bleeding type, patients fabricating or inducing different types of bleeding, and neurologica diabolica, which is sort of induced seizures, paralysis, or other neurological symptoms.
Yeah. And he also noted, and I think we know this now as well, that these individuals often were very skilled at talking about medical conditions. They would travel from hospital to hospital. They called it hospital hopping. And he actually named the syndrome after this nobleman in the 18th century from Germany. His name was Baron Karl Friedrich von Münchausen. And he was known for telling very exaggerated, fantastical kind of stories, including riding on cannonballs, traveling to the moon, pulling himself out of a swamp by his own hair.
And he was a military person. So these were all like his war stories, and he's a war hero and how fantastic he was.
Yeah, it's fun. It's fun until it's not, which we'll get into some of the cases. But yeah, so there was a fascination about this, and there were stories published in literature about his narratives. And
just one more thing about the stories that's so funny. So yeah, his stories were published in 1785. And when he realized that his stories had been published under his name, the Baron, he was horrified because these were just sort of campfire stories that he would tell his friends and exaggerate. And the fact that they had been captured and attributed to him, he was super embarrassed. He actually took legal action back in the day to try to get the book banned and try to get his name removed from it. So even he, which I actually do think is interesting because the sort of catastrophic ego injury, narcissistic injury that comes from being called out on these things is a consideration when treating Munchausen. So you can even see it in the origin of the story creation itself.
Yeah. And it was not until 1977 that pediatrician Roy Meadow observed this behavior not in adults, but in children. And Meadow reported 2 cases. So the first one was a young girl presenting with a significant amount of blood in her urine with no apparent clinical explanation. And the second case described the mother who administered toxic doses of table salt to her child, which led to multiple hospitalizations, extensive testing, ultimately resulting in the child's death. So he actually, at this point, extended the concept of Munchausen to include caregivers who induce or falsify illness in a child, calling it Münchausen Syndrome by proxy. This is 1977. So over time, the idea of Munchausen has expanded, and now it's considered just an extreme form of factitious disorder. So factitious disorder is when someone is fabricating an illness, a medical condition, to play the sick role without an external secondary gain. There's no obvious financial or material gain, but just to play that sick role. And so it is very much a psychiatric condition. And the Munchausen is an extreme form of that.
Yeah, and I think the fantastical nature, the pseudologico fantastica, is what sort of captures people's attention. But it's not necessarily the hallmark. It really is more the factitious disorder part of it and the difference between all the somatic disorders and sort of the differential. But that's, I think, what really defines the Munchausen's phenomenon.
And speaking of differential diagnosis that we run through with Munchausen.
And actually, I would back up. I think the first thing is that this is a diagnosis of exclusion, that you always have to consider that there might be some sort of occult underlying, possibly rare, physical cause for the symptoms that are being expressed.
Yeah.
So I will bring up a quick case that we saw when I was in training of a woman. She was a sort of mid-40s who was in the hospital for persistent abdominal pain without really any findings. She had had multiple surgeries and was actually in the hospital. I think I might get some of the details mixed up, but was in the hospital for another surgery and had a number of these signs, was a nurse by training, and we were consulted to talk about what might be happening. And she was adamantly resistant to speaking with psychiatry. This is physical. I know the direction you're going down. That is not what's happening with me. Even the attending at the time, the great Philip Slavny, analyzed the case and continued to say she is not benefiting from this. She's not benefiting from the sick role. Her family is not benefiting. There's no primary or secondary gain coming out of this. This story doesn't make sense. And they found that during one of the surgeries, the surgeon had actually incarcerated her omentum. So she had necrotic omentum in her abdomen that was causing all of this pain. And once they released that, she was fine. So I think even though we can have a parallel track of considering Munchausen's, it's also important to keep an open mind to the possibility that medicine knows less than it knows, and that physical causes are still always possible, even as we're going down this path. So not to get sort of railroaded in one side or the other, that people who may have a psychological component to their symptoms may also have a physical component. Just because we can't find something doesn't mean it doesn't exist. So that's my big soapbox. And now let's assume that everything's been ruled out and we're continuing down the pathway of possible Munchausen's.
Yeah, I think it's a very important point to note that you do have to understand there are concurrent syndromes happening.
Mhm.
So differential diagnoses, so malingering is one, financial gains, compensations, or evading some sort of legal responsibility. The key thing about malingering, which I think a lot of people can tell, it's a very basic instinct, is that they're not in distress. The way they're explaining things, their facial expression, the tone of their voice, their body language, their gestures, they're not in distress. And if they are in distress, it's very exaggerated. And, you walk away and they seem completely fine. And if you think about the brain too, if you think about how much executive function that takes, the planning, the organizing, the lying, that is not going to give you any space for the right hemisphere to emote, right? To express that emotional distress.
And I agree. I think the big component of that is that there's a conscious, specific purpose that the person has in creating the symptoms that they're creating. Whatever that might be, they are consciously aware both of why they're doing it and what they're doing.
Yeah. And then another diagnosis we consider is called the somatic symptom disorder. Now, this is truly the patient is experiencing some physical symptom with distress and without any intention to take on the sick role. So this is a condition felt and experienced, yet we don't find physical evidence for it, but it is something that the patient is suffering from. And similarly, conversion disorder, which is also called functional neurological symptom disorder, this comes with significant distress without the intention of taking on a sick role, but it pertains more to sensory function and neurological conditions with also positive neurological sign that's incompatible with whatever disease that they're complaining about. So there are very important clinical clues
that help us identify Munchausen,
like inconsistent medical history. And this is not so much a poor historian. This is actually the opposite, where they're really good historians and they have the timeline really laid out, and it doesn't really make sense, why they're referred to this specialist or that specialist. So in order to fill in the gap, they may have pretty extensive medical knowledge. They may reference certain conditions that are kind of debated in the field. Maybe they bring up medications we don't use very often.
Sometimes they'll cite papers, they'll cite research. Yeah, they're typically very educated about both the condition they're discussing and sometimes more globally.
Yeah, exactly. And this leads to multiple or frequent hospitalizations, repeated invasive procedures. So you can see some signs, like if you're looking at their abdomen and there are multiple surgical scars.
Yeah, I've heard it called different things, the gridiron abdomen, the tic-tac-toe abdomen, but just sort of the crisscrossing of tons of abdominal scars from the different surgeries.
Yeah, sometimes also the self-inflicted injuries, injecting themselves with toxic chemicals and manipulating wounds, and resistance to psychiatric evaluation. So we'll go into this, but interdisciplinary collaboration is a really important point. Our biggest ally most of the time is the PCPs, the family physicians, the pediatricians. And so there's a pretty noticeable resistance to realizing that this is anything related to psychiatric or psychological issue.
Which is not, I think you can see that in multiple places, but this is a almost adamant resistance to even seeing a psychiatrist, let alone a suggestion that this might be related to mental health or mental wellness in a broader sense.
Mm-hmm. So, one of the things we learn in medical school about this is the Hoover sign, which I had to like go back and like reread like 100 times because it's very confusing. But I think it's helpful to share with the audience how we work with this. So the Hoover sign is a sign to differentiate a functional weakness, meaning this is a felt and experienced weakness or pain, versus a physical weakness, like the nerves and the muscles are not working. So a Hoover sign is positive when you feel a pressure under the leg that is weaker, when the stronger leg is raised. And then you feel no pressure in the stronger leg when the weaker leg is being raised. So essentially, a positive Hoover sign indicates a functional leg weakness. Now,
Right.
that doesn't mean that we stop and say, okay, this leg is fine, we're just going to move on. We actually then take into consideration that there's something about the perception of that leg strength or the experience of that leg pain that is really, really bothering the patient. So we might start with pain management without opioids first, and then talk through what's leading to it, what's triggering it, what are the circumstances. And really the big thing is that we spend time with that symptom. But we're not going to necessarily go in and do surgery or, some drastic measure because we know that the physical strength is actually there.
Yeah, I think we're always trying to figure out the why. What's going on? Why is this happening? And you're 100% right that sometimes, especially in kids, because the Hoover sign really means they're not trying to lift the leg, right? For kids, it could be that you tell them to lift their leg, but it hurts too much, and they're just not going to do that. So there could be multiple reasons aside from what we were talking about, and I think I do think sometimes when we talk about things like the Hoover sign, there's a temptation to fall into almost a power struggle with the patient of like sort of a gotcha. Like, I know that this is not really happening. And so I'm on to you. And I just don't think that serves the patient. I don't think that serves their care. So something to be cautious about.
Absolutely. Absolutely. That's why if you go into medicine, it takes a certain type of person to be a clinician. Because being a clinician is understanding that there is suffering and there's struggle, despite, logically it doesn't make any sense. And so I think if you wanted to really work with patients, you have to sort of put that aside. And if you can't, maybe you should go into research. But I think as a clinician, you really have to balance your urge to correct. So speaking of how to bring out that empathy, there are several theories surrounding Munchausen and Munchausen by proxy. And it's really, really hard to do research in this area because obviously they don't want to see us. A lot of these patients, they want to run as fast as they can the other direction. But there are theories. And this includes a lot of history of abuse, neglect, and instability during childhood for that patient. And feigning this illness often provides a sense of control, some sense of filling unmet emotional needs, and the sick role enables avoidance of some responsibilities or escaping some of life's failures and pressures.
And I think even that sounds very conscious. And I think it's important to remember that in a lot of times in Munchausen's or in factitious disorder, the person knows that they are doing something, right? They are consciously aware of the actions that they are taking, but they themselves don't consciously know why or what it's doing for them. So it's like the idea that abuse can be passed down through the generations, right? So if a child is abused by their parent, then they might then abuse their child, right? And you would think, well, that doesn't make sense. They've been through it themselves. Why would they do that? But we see it over and over and over again. And the person doesn't know why. And if they're in a careful way brought to an awareness of that conflict, a lot of times that's very hurtful to realize that they're doing what they themselves went through. But before that, it's just this sort of automatic system that they can't even pull apart themselves. So I think there is a lot of empathy in understanding that the person themselves doesn't understand what's happening or why they're doing it, even though they are taking those physical actions, if that makes sense.
Yeah. And with that, like unconscious, not being aware of why comes shame.
Mhm.
And, I don't know why I'm doing this, but I keep doing it. And I know I'm doing it. And then with that shame, they use this sometimes as a form of self-punishment that's driven by previous guilt. And for others, it's a form of social isolation, some way to distance themselves from their community or society because they feel like they deserve it. They've been isolated before in the past, and so this is almost like a place of comfort. And then some theorists suggest that the medicalization of daily life and cultural emphasis on victimhood have also contributed to a rise in these cases. That's interesting. It's always a balance, right? With science and medicine, you have some like big finding and you kind of want to chalk everything up to that. But you always have an anomaly because that's just human nature. You're going to have someone who's outside of that standard deviation. And so I think sometimes we lean way too far on one side and then people stop trusting doctors, right? Stop trusting medicine and research because I mean, this gets into a bigger issue of like, where does the funding go? Who gets funded to do all this? Where the drug companies. But I think we have to always be able to balance that sort of, okay, this is the evidence and this is what we're seeing empirically in the field. And so how do we bridge those two together?
It's such an important point, and I think that because people develop very strong feelings on all sides of these issues, the idea of purposefully hurting yourself or purposefully hurting your child is so emotionally tense and emotionally fraught. And everyone always wants the why, but sometimes that's hard to find. And as physicians, sometimes we can even feel like the bad guy in the situation, or we can feel a lot of anger or resentment towards the person who is perceived as wasting our time or sucking up resources that could be available to someone who's really suffering, quote unquote, even though these people are suffering. So, yeah, there's a lot of emotions all over the place.
Yeah. So these are some hard facts that I think we wanted to share. And it's difficult because I don't want to paint like a stereotype, but also I think we need to know the numbers.
Yeah. By the way, welcome to psychiatry. That is the line we stride all the time, that it is our job to make hypotheses and read between the lines and understand humans and human cases and human behavior and epidemiology and what's more or less likely in certain populations, and respect individuality and not stereotype and not lump people into groups unfairly. So, that's something we struggle with all the time.
Yeah, it's so hard in the moment, but it's one of my favorite parts of this job. It's just so nuanced and vast. Yeah. Okay, so the systematic review in 2017 that was done on Münchausen Syndrome by Proxy. So nearly all the abusers were female. So that was 97.6% of the people who were studied. And there was about, I think, 700 cases studied. And most of the abusers were married. And the mean caretaker age at the child's presentation was 27.6 years old. Perpetrators were frequently reported to be in the healthcare-related professions. This was 45.6%. And they have had obstetric complications during childbirth. That was 23.5%. They also had pretty significant history of childhood maltreatment, 30%. And the most common psychiatric diagnoses recorded were factitious disorder imposed on the self, which was 30.9%, and then personality disorder was 18.6%, and depression was 14.2%. Probably a lot of underestimation just looking at this, especially in the childhood maltreatment, the psychiatric diagnosis, personality disorders. But that's what's out there. And I think it speaks to childhood abuse and what that means and how that affects women particularly. We talk a lot about what it means to have something psychiatrically manifest versus physically manifest, and how like it's just so much easier to channel that into a physical world because of not only stigma, but really your body knows to do that. So as women, I think it's been years and years of oppression that you just really don't know what to do with. And these things will come about and physically manifest. Now, I do think this is truly psychiatric to the point where we have to intervene psychiatrically, but also you have to give room for empathy for what these women have been through and are not able to talk about.
Yeah, that was very well said for a sensitive issue.
Thank you.
The only thing I would bring up is the distinction between Munchausen's and Munchausen's by proxy. I think it is a little harder to understand, even, say, self-injury. That has become more common or more commonly understood. But imagine somebody who cuts themselves for release of emotional pain, and then imagine someone who cuts their brother for relief of emotional pain. It's a different level, it's a different phenomenon. And so I do think there's a different emotional response to factitious disorder or Munchausen's disorder imposed on self versus imposed on someone's child, where that's your responsibility is to take care of that person. So Munchausen syndrome by proxy, it is officially categorized as a form of child abuse. It's medical child abuse. So that's important to understand because it puts it in a different category where there are certain rules and regulations and mandated reporting and things around that. It is also more rare, we think, than Munchausen's itself. So very hard to do research on this, but about one case per 200,000 children. Mm-hmm. Infants are actually at much higher risk, which is interesting. That's almost 4 times 2 per 100,000. The risk factors for perpetrators are somewhat similar: female gender, unmarried status, which also places people at higher risk for everything, for socioeconomic stress, for emotional distress, employment in a healthcare field, which goes along with the medical knowledge. And then there's some, I hesitate to even say this because it brings up so much, but it's more common to have a history of a personality disorder, which is somewhat recursive because that might have been diagnosed because of the actions taken during Munchausen's, right? And some sort of a personal history of abuse or trauma.
Yeah. It's interesting because I think cluster B and borderline personality, that's what comes up with Munchausen by proxy. But the borderline initially was conceptualized between neurosis and psychosis, right? So if you hear that borderline hysteria kind of presentation is on the fringes of a psychotic condition. And also on the other end of that is that you get very neurotic and obsessive about certain things. So there is a lot of stigma with borderline personality disorder and histrionic personality disorder, but I think it's helpful to mention because you are on the spectrum of neurosis to psychosis and you're fighting for stability. So there are 2 cases we want to talk about. And the first one is Gypsy-Rose Blanchard. And we just want to say also that this is by no means a medical diagnosis or any sort of evaluation. We also understand that they have their own stories, their own perspectives, their own rights, and we don't want to infringe on any of that.
Right. We haven't interviewed these people. We don't know these people. We're just retelling facts as they've been presented in the media, just as people. So the official diagnostic hats are off. We're just using this as a tool to further explain the topic that we're discussing.
Right. So, and I think a lot of people know this story, but Gypsy-Rose was a child who was under the care of her mother, Dee Dee Blanchard. And Gypsy-Rose suffered about a decade-long abuse under her mother, who fabricated leukemia, muscular dystrophy, and developmental delays. She was confined in a wheelchair, which was unnecessary. She was able to walk. She had a feeding tube. She had multiple surgeries, invasive surgeries. They even had Habitat for Humanity build a house for them because of all of the spreading of this story and how heartfelt it was for a lot of people. And so, speaking from the perspective of the child, when you are a child and you have a primary caregiver, there is nothing in the world that's more important than ensuring that you stay connected with that caregiver. And at the same time, there is going to be a moment where the child is going to realize that this is not useful to me anymore. This is not helpful to me anymore. And I think that's what happened was when she started going into adolescence, she started to pull away. And she met a boyfriend and they conspired together to murder her mother, Dee Dee. And at the end of the long trial, she was convicted and she was sentenced to 10 years in prison, and her boyfriend was sentenced to life in prison. And she recently got out of prison. So she essentially served less time than she was sentenced. And there's a lot of debate about this. And I think there's a lot of feelings about this.
I mean, it's an intense case. And there are documentaries about it, and there's a lot that's been written about it. And so please form your own opinions. But I think the idea that gets people so hung up and is the most divisive is, was this justifiable homicide? Did Gypsy-Rose murder her mother either in some sort of self-defense or self-protection, or in the more extreme cases, a almost justified revenge for everything that had been done to her? I am not anywhere near evolved of a human enough to comment on that. It's tough. In a way, yes, she went through absolutely horrible, unthinkable a decade and a half of abuse and stunted development and stunted growth, and will be carrying that for the rest of her life. And is murder ever justified? I don't know. I think this gets into ethical questions that are really deep and really profound and complicated. I think that the history is pretty emblematic of what we're talking about, the Munchausens. I actually haven't seen any sort of forensic analysis or in-depth analysis of Dee Dee Blanchard and whether this was truly Munchausen's or whether it was more a form of malingering. That's been suggested as well, that Dee Dee Blanchard did know precisely what she was doing and why she was doing it to get all of these financial benefits that came from this. So I just don't know. Like I said about medicine, I put myself in that category. I know less than I know, but this is probably the most or one of the most extreme cases that I've ever heard of.
Yeah. I was thinking about, what is the role of the healthcare field in this? Because Dee Dee must have been a very bright lady, had a lot of knowledge. She had like a closet full of medication. So she obviously knew how to work the system. But I'm also imagining that at some point in this decade, that healthcare professional has some hunch, right? Some sense of like something's off here. And so what really makes me curious is, did somebody say anything? I think the doctor even put in his documentation that Munchausen by proxy is possible. As soon as you put that, you are suspecting of child abuse, which is an immediate action to report to Child Protective Services. So I think there is a failure of the system. And I know it's not one doctor, it's not one nurse, right? It's like the system as a whole is ignoring something that isn't quite right. I think that was the thing, is like, how do we go for so long, especially for a child, right, without noticing that something is off here?
Yeah, and I think that applies to everyone, to healthcare providers, to teachers, to who knows if babysitters were involved. It's one of the reasons for the mandated reporting laws and protections around that, which we'll talk about because there was a more recent case where that actually came into question. But the ideal of the responsibilities of the system is to protect children from any sort of nefarious input, whether that be from external sources, from illnesses, or from their guardians. So I think there is a clear failure of the system. Where and who should have intervened is more of a question.
Right. Speaking of the systemic responsibility as a community, another case that's really famous is the case of Maya Kowalski. And this is in the very famous documentary, Take Care of Maya. So what happened was that in October 2016, a 10-year-old Maya was brought to Johns Hopkins All Children's Hospital in St. Petersburg, Florida, for treatment of complex regional pain syndrome, or CRPS, with her mother. And her mother, who was a registered nurse, requested ketamine treatment for Maya's pain because she had been getting ketamine treatment outpatient. So mom was saying that this is what she needs. She's always gotten this. And the hospital staff was like, no, we're not giving her. ketamine. First of all, it was a ridiculously high dose. Maya was receiving 10 times the normal amount for her size, which it's unthinkable. Honestly, it's very unthinkable. We're talking like 1,500 milligrams versus 10. So obviously, I think this hospital was really wary of medical child abuse and reported the family to Florida's Department of Children and Families, DCF. Maya was then placed in state custody and confined to the hospital for 87 days with severely restricted family contact. So I think there were a number of phone calls, but her mother was not allowed to see her, and it was devastating for the mom. And in January 2017, after being separated from Maya and facing ongoing child abuse accusations, very sadly, Maya Kowalski, the mom, died by suicide. And so from there on, a slew of lawsuits, legal action here, because now there is a suicide involved. The lawsuit found the hospital liable for imprisonment, battery, and fraudulent billing and inflicting emotional distress, wrongful death, and medical negligence to Maya. So they were charged with having to pay hundreds of millions of dollars. Now they're trying to appeal that and reduce that charge. This case led to a change in the mandated reporting, and many suspected cases of child abuse and neglect going unreported, and or hospitals refusing to treat or retain cases of suspected abuse.
Yeah, that was the concern, the potential legal ramifications of such a famous, well-documented case that regardless of the fault or liability, that the fear of something similar happening to a healthcare system or to an individual provider will actually put lots of children at risk of abuse that goes unreported.
Yeah, I think it brings back what we were saying earlier, which is that, once you suspect child abuse, it's kind of like hands off. There's no commitment to help this person because you label them as a criminal. And our argument, because of the work that we do, is that Münchausen by proxy, Münchausen Syndrome, is a psychiatric disorder that we have to work with. It's not malingering. This is a situation where oftentimes there's extensive history of abuse, whether conscious or not, and neglect, whether conscious or not, and it's manifesting in a way where they can ensure continued support and care by the hospital, by others, because they have no other means of self-value.
Yeah, to quote the great Dr. Philip Slavny once again, in another case that was similar, he would say, they're not having fun. This is not enjoyable to them. They don't enjoy getting one over on the healthcare system. This is way deeper. And it's not conscious in that way, that they are suffering the whole time this is happening. And, I think that's helpful to keep in mind. It helps to build empathy, that this is not a positive experience for the person going through this, or the person, if you want to use that term, perpetrating this.
Yeah, and I think even after watching some of the documentaries, the one thing that does kind of help me reframe is that if you are doing some level of empathic intervention, you are saving millions of dollars wasted in hospital care, in tax dollars. CPS was involved, hospital equipment, surgeries, doctor's time, nurses' time. All of these resources are misused, wasted because we are looking the other way, not giving these people that empathy that they really, really need. And so if you look at the grand scheme of things, that does help. I think it helps me continue to provide that empathy because I can see that, okay, maybe 10 years down the line, this would happen. And if I could intervene now, maybe it's a pebble in your shoe, but it's a pebble in your shoe. You do it enough, you're going to stop that person moving forward. And so, yeah, it's a very difficult thing, like emotionally, holding on to things that are frustrating and holding back.
And that's why we have peer supervision, and that's why we talk about these cases. We sort of air this out. None of us are robots, and the best psychiatrists have feelings too. It's not that we're sort of automatons just going through this, and it prevents burnout to be able to discuss the cases, both the positives and the more difficult parts.
Mm-hmm. So to summarize, we're saying that Munchausen itself is an unconscious, unrecognized process. And malingering is an intentional, deliberate wanting to get something, whether it's money or viewers or subscribers. Differentiating those two things is really important. You might ask, well, how do you know they're pretending to want to take on the sick role, but they're really looking for money? And how do you know both things don't exist? And that's when it is tricky, because with Munchausen, inevitably, we have lots of countertransference. And I can't believe that other fields of medicine don't talk about this. When you start to get that annoyance or frustrations or irritability or just lots of feelings about this patient, that is in our world called countertransference, and we use it quite a lot, not in a way to label a patient and categorize them, but to use it as data and guide our treatment. When I feel that countertransference, I'm actively engaging to push back on that frustration and then go the opposite direction of empathy and respect and understanding. And I know this feels radical in a way. Why would you do that? They're taking advantage of the system. But research has shown over and over and over again that approaching these patients that you suspect have Munchausen or Munchausen by proxy, approaching them with empathy and support rather than confrontation is a much more effective strategy. So with that, we do recommend a lot of interprofessional approach to care. So most of the time they go to their pediatrician or family doctor, right, with these symptoms. And you might consult psychiatry, bringing in like maybe aspects of depression or anxiety. And then you might bring in rheumatology, endocrinology with different symptoms that are usually vague. And it is important to remain in contact with these specialists because the goal of treatment is to avoid unnecessary procedures and prevent further self-harm. It's a form of self-harm, right? It's almost like if they don't feel sick, they don't have any value. They don't have any sense of identity. So you make yourself sick to create that sense of value of yourself, your worth. So the goal is to avoid this perpetuation of self-harm and avoid unnecessary procedures, and also avoiding any sort of like angry, high expressed emotion, threatening interactions with the patient, because that only drives in the point that they get attention from this. Even if it's negative attention, they get attention. So that is a very difficult point to communicate, but it's such an important point.
And I think there are ways that we have of addressing that and controlling that, whereas I think you're right. It's very easy to see this as this person is a drain on the system, or they don't really have what I'm here to treat. Just get them away from me. Just get them out of the clinic. And actually, the contrary is usually the more effective approach, more frequent but shorter visits, more touch points, more access to the person to figure out what's really going on and what's happening underneath that. And I think paying attention to our own countertransference and transference is, you're right, super important, not just sort of allowing that to be there, but a lot of times that's a clue into what might be going on and help us decide how best to treat the person who's in front of us. So yeah, I agree. I don't know. It's funny now, I don't know how I ever didn't pay attention to that or sort of recognize that and take that into consideration when treating patients. But yeah, I think that's not really a recognized component. And, it sort of goes without saying, but we're using words treatment. So this is mostly what we're talking about, how to respond in a professional capacity, as opposed to if you're a family member. That is a different type of approach. I mean, we're talking about transference and countertransference, but those feelings are going to be 10 times stronger if it's a family member or someone who you're intimately connected with in that way.
Yeah. And I think the difference there is that if you're a family member, you can make your boundaries known.
Mm-hmm.
You can tell that person, hey, I love you. I care about you. I cannot allow this for my own sense of well-being. And so to communicate that, I think as a family member, you have the right to do that. As a provider, as a clinician, that gets really tricky. I think you still have to lay out boundaries, but at the end of the day, you're always putting the patient's best interest at the forefront. And so if it's really harmful right now to say, hey, I don't think you're telling the truth, and you haven't built rapport, you haven't built trust, you haven't convinced the patient that you are working hard to understand them, this is just not a good approach. And I think I also understand as physicians, you are working within the constraints of the systemic thing of insurance companies are demanding this, the hospital administration's demanding this and that. You only have so much time. So you don't have time to sit there and be empathic. I get that. But even if you're not able to utter the words, if you have this mindset, people can feel it, especially people with Munchausen, because they're so perceptive to what others think of them. That's the entire point of their symptom, is that they worry about how they come across to other people, because that's where their values lie. And so even if you don't have time, if you can kind of keep that, the idea of countertransference, the idea of they want to play the sick role to fill a void, that they have no sense of self, and that they don't know that they're doing this. I think those things are just important to keep in mind.
Yeah, I think they don't know that they're doing this is a really important one. And another one that one of my attendings would say sometimes when this entered the discussion, and it would bring up a lot of feelings in us, why do we have to keep seeing this person, or they keep coming back? And he said, would you change places with them? Do you think they're like, this is something that they're winning and you would trade places with them? No. So how can we help this person get to their goal? And I think that's the other thing, is that this is to serve a purpose. We may not know what it is. The patient certainly doesn't know what it is. But if we can help figure that out and find a different way to address that need, a lot of times that can be the most useful thing to extinguish this, as opposed to calling somebody on it. It's almost like, and I hesitate to give this example because it's in no way trying to mix these two conditions together, but it's almost like someone with psychosis. You can sometimes gently try to reality test, but if you directly confront a delusion, sometimes that crystallizes it and makes it stronger, or leads the person into sort of a deeper sense of panic. And this can be similar. If you do a direct, hardcore confrontation into this unconscious behavior or activity that someone's enacting, they'll just get sicker. Really. That's not going to help.
Yep. They'll feel more isolated. They'll think you're the enemy. So it further distances you from them.
And so sometimes the model that we use of seeing somebody on a frequent basis to check in with them, in psychotherapy, we see our patients once a week. In medicine, especially some of the consult services, you see somebody once a year. So having those more frequent touch points where the patient knows, I'm going to see this provider again, they're going to make sure that nothing terrible is happening to me, can really reduce or alleviate a lot of the unconscious need to hyperbolize symptoms in order to get that attention or recognition or security. And that's the other thing that we don't talk about all that much, that there is an overlap with health anxiety and Munchausen's as well, that sometimes the symptoms that are being presented may not necessarily reflect a real underlying condition, but they are a hyperbolic response to the fear that some condition exists. So like, I need this MRI, I need this CAT scan, I have this weakness, or I have this whatever. And really, it's just, I'm afraid that I'm dying. If you can tell me I'm not dying, I will feel better. And so those more frequent but briefer touch points can alleviate some of that anxiety and consequently some of the symptoms.
Yeah, and it's even more powerful when it's coming from a team of providers and one consistent provider. So that's one of the things that actually is recommended, is that you have, whether it's a primary care physician or a psychiatrist or a therapist, somebody who is consistent throughout all of the ins and outs of their treatments, hospitalizations, procedures, so that you have a record of what exactly has transpired. And over time, that one consistent provider can compile this data and just show them, hey, take a look. I've been seeing you for 3 years. Take a look what's been happening. And to talk through it can sometimes bring that perspective of like, what is the bigger picture here? What's the bigger role? And so that combination of multiple different providers and one consistent provider to follow you is really key.
Mhm. So some other treatment recommendations that we always follow up on include psychotherapy, and that can be presented different ways because sometimes people are attuned to the idea that someone doesn't believe them or thinks this is all in their head. And so the idea of you should see a psychiatrist, you should get psychotherapy is met with, I'm not crazy, or this isn't in my head, this is a physical thing. And so there can be a lot of resistance to that. So sometimes the presentation is, wow, it must be so stressful to have to go in and out of the hospital, to keep all of these doctor's appointments, to have to get up every day with how much pain you're in. But there are ways to cope with that, like psychotherapy to deal with the stress imposed by the condition, as opposed to help you figure out that this condition is not real, can be a much more open and less, again, power struggle-y way to present the idea of psychotherapy to somebody.
Mm-hmm. Right. I'm trying to kind of wrap my head around the argument that your mind might make for this, right? Because you're not feeling symptoms, but you believe you're sick and you're seeking help. And in this kind of cycle, if you were getting what you needed, I guess why would you stop? Yeah, it's like a kind of a psychic level of pain. You know, it's like we have to conceptualize it that way. Just because we can't see something doesn't mean it's not there for that person.
Right.
And I think that idea in general is missing from medicine. We're very data driven, we're very quantitative. It's like if you don't have evidence for it, it's like the other day I got asked, do you think we need brain imaging for treatment or diagnosis of psychiatric conditions? And I don't think the research is far enough. But it's almost like, what is the need for us to see physical evidence if the subjective experience is evidence enough? What's the need there? And the need is that in medicine, you have to have proof of something. That's just what we're taught. But we don't really value a lot of that subjective experience. But the subjective experience for us, that is all we need. So you do your due diligence, you do the organic workup, and then if nothing comes to fruition, then you realize that there's a self-serving system. I guess, Dr. Kelly, my question would be like, if you're confronting a patient like this, what would be the language that you're using? If you had to gently confront, how would you say it to them?
I think there are many ways to explore that. And it's sort of like most of psychotherapy, quite frankly, where there's a skeleton, but there's no one perfect phrase to address it. It's that dance with the patient to see what resonates with them, right? Like if you're doing a CBT exercise and you're trying to get somebody to see the real evidence of the situation, sometimes you'll say, well, what would you say to a friend to sort of de-identify it and get them out of their emotion? Sometimes you'll say, well, your best friend, what would they say to you? Sometimes I'll go with the idea of absence of evidence is not evidence of absence. We haven't found anything to explain your symptoms, but before the advent of more advanced imaging, multiple sclerosis was considered a psychiatric condition. Epilepsy was considered a psychiatric condition. So just because we can't find the biological reason or treat the biological reason doesn't mean there isn't one. However, it does mean that there's nothing more that traditional medicine can do to address this right now. So let's address the suffering that comes from this in the best way that we can, which is in my field, is in therapy, is in medications. So sometimes that's what works. We don't have to have the definitive diagnosis in order to help them feel better. And sometimes it really is digging more into the reason behind this, the driving force. And a lot of times, I don't want to say ignoring, but acknowledging the physical symptoms, but choosing not to dive into it as much, putting it aside almost in an ACT way. So if someone can't walk and they come in a wheelchair, then you just let them do that. Or you just say, how are you doing? Well, oh my gosh, it's been so terrible and I have these doctor's appointments. And you sort of cut that off and say, yeah, but how are you feeling about that? Not what are your appointments? What are the feelings that are that can be remarkably difficult for someone to access and talk about. And then you do more traditional psychodynamic psychotherapy, and figure out the need behind this. Is this an unmet need for love? Or is this a stress response? Or what is that? And as the cause is addressed, the symptoms themselves reduce without ever having to talk about them. So not a direct confrontation, but trying to get behind it. So I think there are lots of different approaches, but they come down to the idea of the solution to your problem as you've experienced is probably not in more procedures or the traditional field of medicine. Let's help you feel better while you're going through this process.
Yeah, I 100% agree. And I think you have to do a shout out to psychoanalytic, psychodynamic therapy here, especially in this type of diagnosis, because they feel helpless. They feel like there's no solution. And there's projection of that onto you as someone who's supposed to help. And so I find that sometimes if you just kind of say, we've tried everything, we've had you talk to different specialists, and we've exhausted everything we have. Frankly, I don't know what's going on. I'm not going to give up. I'm going to keep trying to figure this out with you, but I don't know. I'm kind of at a loss here, but I'm going to keep going with you. So acknowledging that helplessness that you feel is sometimes relieving because they feel like they're not alone. They feel like they're not crazy. And you share in that intersubjective experience, and that itself is an intervention. We do feel helpless and we feel frustrated. So it's real and it's true and it can be healing. So going back to what you're saying about what's missing, what's really behind this, you can have that conversation, but not without the acknowledgement of what's in the room. And that's what psychodynamic, psychoanalytic therapy is so helpful, and understanding countertransference. And transference is helpful because you can't just jump straight to, well, what happened in your childhood? What were your parents like? You can't do that. You have to have some sort of bridge. So I think acknowledging what's in the room, checking in with yourself about what's triggering you in order to take care of this person. When do you need a break? The more I do this, the more I have so much respect for psychoanalysis, psychodynamic approach, because it's one of those things that it's just always there. Between two people, it's always there. But when you can use it to your advantage, it's extremely helpful.
Yeah, absolutely true. It's helpful to realize it's always there, right? There's always a dynamic between two people. You're never a robot in the room. You're never disconnected from that or separate from that. And so if a patient comes in really seeking an answer and wanting wanting you to fix it, you feel that, and that resonates with especially medical providers so deeply. And then, so there's some literature in medicine on the difficult patient or the help-seeking, help-rejecting patient, the person who comes in and says, I need you to fix this. And you say, well, here's how we'll fix it. And they say, well, no, I don't want to do that. And the frustration of that. And I think that sort of, you need to fix this, that's our need. And that may be something that the patient is projecting onto us that we're picking up, but it's because we're I guess, vulnerable to that resonance in medicine. That's our job, is to fix it. And sometimes that's not our job. And I think not having the answer and sharing that with the patient, sharing that ambivalence, it can feel very vulnerable on our side, like we're supposed to have the answers. But sometimes that, like you said, that is the intervention.
Yeah.